Bueno, buenos días a todos. Gracias por venir al desayuno de Grand Rounds Zona Pediatrica. El día de hoy tenemos el placer de presentar a la doctora Nirsevimab. La doctora es profesora de pediatría médica en la Universidad de Vanderbilt, en Efficacy, y ha realmente liderado muchos de los estudios tribunales que se han realizado en vacunas que han sido licenciadas en las décadas pasadas a lo largo de la historia de las vacunas en Estados Unidos, en otros países. La doctora se graduó en la Universidad de Iowa, en la Escuela de Medicina, y completó su escuela de pediatría y su fellowship de enfermedades infecciosas en la Unidad de Northwestern. También hizo un entrenamiento de posgrado en inmunología en la Universidad de Rush, en la Escuela de Medicina en Illinois, y luego se unió al programa de vacunas de Vanderbilt en 1980. Ha tenido múltiples ocasiones en CDC, en el NIH, en el FDA, en la Universidad de la Salud, y en ISA, que es la Asociación Americana de Enfermedades Infecciosas, en comité en las cuales de vacunas y productos biológicos relacionados. Así es que para nosotros es un gran honor tener a la doctora con nosotros, y el día de hoy nos va a hablar sobre prevención de virus incisional respiratorio y qué es lo que hay de nuevo. Catherine, thank you for coming to our conference today, and the microphone is all yours.
Thank you. I'm very pleased to be here to talk to you about some new exciting news about RSV prevention in young children. I have some disclosures. I've been funded by the Centers for Disease Control and NIH. I'm also a consultant to Iliad AstraZeneca, and I serve on a number of data and safety monitoring boards. Today, what I'm going to discuss first is a little bit of an understanding of the structural basis of immunity to RSV, because it really has made a difference in how that we can prevent disease. I'm going to talk a little bit about the impact of RSV disease on young children, and then I'm going to spend most of my time talking about the prevention approaches for RSV. First, vaccination during pregnancy, and second, the administration of monoclonal antibodies to infants. I'm going to outline the efficacy and safety of each of these approaches, and I'm going to review the options for RSV control. Much of the data that I will be presenting is from the United States, but I think based on the epidemiology of RSV disease, the implications of how this can be used in Guatemala will also be clear. So RSV was discovered in 1956. It's an enveloped negative strand RNA virus, and there are two subgroups within RSV, subgroup A and B. The two most important proteins associated with RSV are G and F. G mediates attachment to the host cells, and F is the fusion protein, which allows the virus to fuse to the respiratory epithelia. This particular fusion protein is very important, and antibody against that protein is what is important in preventing disease. So all of the approaches we're going to talk about today target this fusion protein, which you see right here. The fusion protein, until recently, was not very well understood. But in the past several years, it's been made very clear that the fusion protein exists in two forms. One is a pre-fusion form, which is the structure of the virus before it attaches, and another is the post-fusion. Now look and see over here on the right the neutralizing potential of the virus is neutralized primarily if it's directed against the red and the orange. And as you can see here, the red and the orange are presented by the virus in the pre-fusion form. So all of the viruses and all of the vaccines are going to be in this pre-fusion form, which will allow much more antibody to be generated. Several years ago, there was a vaccine that was in the post-fusion form that was given to mothers to look at protection against their infants. And it did not work simply because the epitopes or the important sites for RSV that are shown there are not very neutralizing, as you can see here. RSV in the United States and most all over the world is the leading cause of hospitalizations. It can affect the small airways in the lungs, particularly in infants. Most infants, 2/3 of infants, are infected during the first year of life, and nearly all infants are infected by the age of 2 years. Overall, in the United States, between 2 and 3% of young infants are hospitalized with RSV. Over 80% of those children that are hospitalized have no underlying medical conditions. And prior to 2023, there were no long-acting products that were available for the prevention of RSV. Each year in the United States, in children under 5, there are 1.5 million outpatient visits for RSV, nearly 500,000 emergency department visits, between 58 to 80,000 hospitalizations, and between 100 to 300 deaths associated with RSV. The global burden of RSV compared to influenza is shown on this chart. It is anticipated and projected that each year in children under 5 years of age, there are 33 million episodes of RSV infections, 3.6 million hospitalizations for severe illness, and 100,000 deaths. As you can see, this compares quite well and in fact is larger than the impact of influenza in young children. RSV hospitalizations are highest in infants less than 8 months of age, and the highest rate of hospitalizations is at 1 month of age. So what we need to prevent RSV in babies must be administered very early, because within the first month of life, they're the greatest risk for RSV disease. RSV was, as I said before, discovered in the 1950s. So why has it taken so long for us to have a prevention strategy? Well, shortly after the discovery of the virus, a formalin inactivated RSV vaccine was generated in the 1960s. When that vaccine, however, was administered to young children, it caused severe lung inflammation when natural RSV occurred. Not only did it fail to offer protection, but it caused an exaggerated immune response when children were infected with RSV. In fact, pneumonia was seen in children 6 to 23 months of age in 69% of those children that were vaccinated, and in only 9% of those children that were non-vaccinated. This particular vaccine was associated with 2 infant deaths when the infants acquired RSV. And this is a picture here of the child who died of RSV after administration of vaccine. That episode led to the delayed discovery of vaccines and prevention, and has been fraught with a lot of difficulties. More recently, a small study in infants of an mRNA vaccine was associated with enhanced disease, not with deaths. So we have not been able to generate a vaccine that can be given to young babies before they're infected with RSV to prevent disease. So it has to be done in another way, in two other ways. And that's what I'm going to be talking about today. So the first vaccine that was approved for use in mothers was based on this study that I'm going to outline here. This is a vaccine, a pre-fusion F vaccine developed by Pfizer that was given to mothers during their pregnancy. In this study, pregnant women were immunized between 24 and 36 weeks gestation with 120 micrograms of an RSV vaccine, half containing RSV-A, half containing RSV-B. Nearly 3,600 mothers were given the RSV vaccine. Nearly 3,600 were given the placebo in a blinded fashion, and their babies followed for disease. As you can see here, once the babies were born, active surveillance for RSV was conducted in the babies. Families were called each week during the first 6 months and were called each month during the month after that. These babies were seen when they had respiratory illnesses. RSV was cultured for or was tried to be determined by molecular techniques, and the symptoms that the babies were having were determined. I was part of the committee that looked at these cases in a blinded manner to adjudicate whether they had severe disease. And that was the major outcome. Severe disease was associated with a decreased oxygen, with retractions, and with hospitalizations and the need for oxygen. The data from the maternal vaccine study is shown here. All of these cases were confirmed by the adjudication committee. Severe respiratory disease in the infant by maternal vaccination in the first 90 days after birth was 81% effective, 120 days after birth, 73%, 150 days after birth, 70%, and 80 days after birth, 69%. These studies were reported in the New England Journal of Medicine, and these are shown here. You can see that that's for severe RSV associated lower tract illness up here, that the rates of incidence were much higher for placebo than for vaccine, and also for lower respiratory tract illness as well. In August of 2023, this vaccine was approved by our FDA. However, it was approved in a more restricted gestational age because there were some premature cases that were seen earlier, and although not achieving statistical significance. So the recommendations were for the vaccine to be given at 32 to 36 weeks gestation, not as it was shown in the study between 24 and 36. In addition, at about that same time, a monoclonal antibody against RSV, against the pre-fusion form, was generated. This was a recombinant vaccine, a recombinant immunoglobulin that was an IgG1. It bound those F1 and F2 subunits of the pre-fusion, which are shown here in this particular area. It was modified so that the half-life of the monoclonal would be longer, that it could just have to be administered one time, a single injection, and this would target all infants for prevention of RSV given directly to the infants. The pre-licensure data that were used for licensure are shown here. They also were published in the New England Journal of Medicine. And the Nirsevimab was found to be effective for the prevention of RSV in healthy late preterm and term infants with 75% efficacy against medically attended lower respiratory tract disease. And in preterm infants was found to be 70% effective against medically attended lower respiratory tract disease. So in September of 2024, in the United States, 2 products were recommended by the FDA, and those were then recommended by the CDC, by the ACIP, for prevention of RSV disease. One was the prevention of infants during their first season in those infants less than 6 months of age. And that was either with the maternal RSV vaccine by Pfizer or with the use of Nirsevimab in the infant. The administration of both products, however, was not needed for most infants, just one or the other. Children 8 to 19 months of age who were at increased risk of RSV disease in their second season were to receive the Nirsevimab. The timing of this was also carefully outlined in that the maternal vaccine could be given in pregnant women between 32 and 36 weeks gestation in the United States, meaning that pregnant women could be vaccinated between 32 and 36 weeks gestation between September and January. The Nirsevimab should be given to infants less than 8 months of age and shortly before the season onset, which would be in October, and that infants should receive the monoclonal between October and March within 1 week of birth. This diagram shows the administration, when the administration of vaccine should be given to the mother, when the administration of the monoclonal should be given to the infant. This particular chart can be modified upon the time of the onset of RSV season in your country. So if RSV season begins in August, then this whole chart can be moved back 2 months. It was shown, however, that once the season began and implementation began, that there were a number of challenges. And there were reports, as shown in the box, that pregnant people were getting the RSV vaccine that was for older adults, and that was not appropriate. It was not licensed for use in pregnant women. There were reports of children getting the RSV vaccine instead of the monoclonal antibody. And there were reports of the administration of the actual wrong dose of the Nirsevimab. So with these 2 products licensed, it does need to be very carefully determined what the mothers get and what the babies get. When the season, the 24-25 season in the United States was looked at, the following information became apparent, and I think is very helpful for you as you roll out your new vaccine. Overall, around 40% of pregnant women were vaccinated with the RSV vaccine. There were differences in the ethnic backgrounds of those people who accepted the vaccine. The highest number were in individuals who were of Asian descent, where about 50% of them received maternal vaccine. However, in our Black non-Hispanic population, around only 25% of the pregnant women received the vaccine. The vaccine, the maternal vaccine, was highly effective in preventing emergency department visits with an efficacy of 54%. For the prevention of hospitalization, it had higher efficacy, between 79 and 70%, depending upon which surveillance system, either Vision or NVSN, was used. Data from other countries was similarly very encouraging. Maternal RSV vaccine effectiveness in Argentina was found to be associated with 81% efficacy for prevention of hospitalizations, 79% for in another study in Argentina for RSV hospitalizations, and 79% in another study in infants less than 6 months of age, all in Argentina with maternal RSV vaccines. In the United Kingdom, for prevention of hospitalization in children less than 3 months of age, the vaccine was found to be 72% efficacious. So again, the ballpark suggests that for prevention of hospitalization, the vaccine given to the mothers in between 32 and 36 weeks gestation was around 70% efficacious for prevention of hospitalizations. The vaccine was also found to be very safe. In 14,000 pairs of pregnant women, when they were compared, there was no increased risk for fever, fatigue, stroke, seizure, Bell's palsy, ITP, pulmonary embolism, preterm births, infants being small for gestational age, or stillbirths. There was a slightly increased risk for the hypertensive disease of pregnancy with an odds ratio of 1.09 and with preeclampsia with an odds ratio of 1.212. The severity, however, of this hypertensive disease was similar among vaccinated and unvaccinated individuals. When it was looked at for the uptake of Nirsevimab, in contrast to the maternal vaccinations, between 21 and 48% of infants aged 0 to 7 months of age received Nirsevimab. And you can see from the map of the United States that the uptake was very variable in the many states. The uptake was very high in populations in Alaska, where the native populations were targeted. But in some areas, as you see here, the rates were very low. So overall, between 21 and 48% of infants received Nirsevimab. The effectiveness of the Nirsevimab is going to be shown on the next several slides. Again, 2 surveillance systems were assessed: the Vision surveillance system and the NVSN surveillance system. You see here, for prevention of RSV-associated emergency visits, the monoclonal antibody Nirsevimab was between 63 and 79% effective. When one looked at the effectiveness, again, of Nirsevimab in these 2 systems against hospitalizations, the effectiveness was 79, between 82% effective. And I think you'll see here that with each of the studies, as the more severe disease occurred, the vaccine or the monoclonal antibody Nirsevimab effectiveness increased. And indeed, when you look at those infants who are administered with RSV-associated intensive care admissions, the vaccine efficacy was between 82, 88, and 80%, depending upon the surveillance network. So again, you see that for more severe disease, the Nirsevimab appeared to be higher effectiveness than for milder disease. So the Nirsevimab safety was also looked at in a large safety data link, where nearly 40,000 infants who had received Nirsevimab were assessed, were compared with reactions associated with the time of Nirsevimab administration compared to the time that was outside of the Nirsevimab administration. There was no increased risk for seizures, ITP, drug reaction, sepsis, or fever. There were no cases of anaphylaxis, and there were 18 cases of hives that were associated with Nirsevimab, but that did not lead to anaphylaxis or any severe outcomes. So the administration of Nirsevimab in the infants was also very safe. Let's look at protection then in the 2004 to 2005 against RSV disease in those children less than 8 months of age. And you'll see here that that what is shown in the boxes are the infants that received the Nirsevimab in the light blue, the mothers that received RSV vaccination in the dark blue, and you can see overall that about 57% of the infants that were born between April 2024 and March 2025 were protected either by maternal vaccination or by Nirsevimab. So a little bit more than half of the infants were protected. What was shown here is looking at different surveillance networks that comparing Nirsevimab and the maternal antibody in the various systems, that by and large, Nirsevimab and maternal vaccine generated comparable efficacy for prevention of emergency room visits, hospitalizations, and intensive care visits. And just as we saw before, that the effectiveness appears to be greater with the more severe RSV disease. Overall, when one looked in the surveillance systems in the United States and targeted infants less than 8 months of age, between 0 and 7 months of age, who were eligible for protection by Nirsevimab or the maternal vaccine, that the RSV hospitalization rates were reduced by 38% and 31% compared to the seasons before the product introduction. So with the RSV net, you'll see that before the prevention strategies and after the prevention strategies, that there was overall about a 40% reduction in RSV hospitalizations. In the NVSN network, there was about a 30% reduction. And remember, only half of the children were able to get the product. So suggesting then that the vaccine and the monoclonal antibody were highly effective. It's also interesting to note that there were no reductions in the burden of disease in those individuals who did not receive either maternal vaccine or the antibody. And this particular RSV season was a very severe one in the United States. So suggesting then that these products, both the vaccine and the monoclonal, had a lot of impact. In addition, when one looked at the very youngest children between 0 and 2 months of age, those that were at highest risk for hospitalization, there was even a greater reduction between 74% in the RSV net group and 46% in the NVSN group, with no significant changes seen in those who did not get the protection. In addition, there were a number of wonderful studies that were conducted throughout the world. This is an amazing study by Spain, where the coverage of Nirsevimab was between 79 and 88%. Wow. They found that this was 80% effective in preventing hospitalizations in infants with lower respiratory tract infections that were positive for RSV. Similar data were generated from England, France, and Germany, where this study showed an 83% efficacy for prevention of hospitalizations due to RSV with the use of Nirsevimab in these 3 countries. This study had 8,000 infants that were randomized to Nirsevimab or to standard care, and this efficacy was clearly shown as well. Again, with the numbers being between 70 and 80% for prevention of hospitalizations. And a number of meta-analyses throughout the world and different areas showed, again, in this for prevention of hospitalizations of around 79 to 81%, as you can see here. So in summary, then, for the 2024-25 season, Nirsevimab was effective against RSV-associated emergency department encounters, hospitalization, and critical illness among infants in their first RSV season. Maternal vaccination was effective against ED encounters, hospitalizations. An estimated 50% of the infants born in the United States were either born to a vaccinated mother or received Nirsevimab. And again, as I showed in the last slide, compared with prior RSV introduction, RSV-associated hospitalizations were reduced by 30 to 40% among eligible infants and by half among infants 0 to 2 years of age in the United States, with about half of the infants getting a prevention strategy. Now, more recently, in the last several months in the United States, another RSV monoclonal antibody has been licensed. This monoclonal antibody, called Nirsevimab, is to a long-acting antibody that is manufactured by Merck. It is given like the Nirsevimab as an injection, but in contrast to Nirsevimab, which must be determined by infant weight, the Nirsevimab is the same dose for all infants, regardless of their weight. The data for the effectiveness of Nirsevimab against disease has not been published yet, but these are our data from the FDA briefing document and are a little fuzzy, but this is the best I could give, so please let me apologize. For the prevention of all acute respiratory infections, it was around 50% effective. For the prevention of hospitalization, it was around 84% effective. For severe hospitalizations and severe disease, around 90%. So again, it looks like it's in the same background rate as was seen for both the maternal vaccination and the Nirsevimab. So the proposed use is going to be that Nirsevimab and Nirsevimab will have the same recommendations for use in infants younger than 8 months of age, born or entering their first RSV season. There will be no preferential recommendation for the use of one as opposed to the other. However, only Nirsevimab will be recommended for those children 8 months to 19 months of age who are at increased risk of RSV disease during their second season. That data does not yet exist for Nirsevimab and is going to be obtained in the subsequent year. Infants eligible to receive Nirsevimab when entering the second season should receive Nirsevimab or Nirsevimab during the first season, but only Nirsevimab during the second season. So the proposed recommendations for all infants less than 8 months of age will be 1 dose for those born entering their first RSV season, with administration in the U.S. between October and March. If the mother did not receive the vaccine, if the mother's vaccine status is not known, or if the infant was born less than 14 days after the mother was given the vaccine, because the mother would not have the ability to make antibody that quickly. RSV antibodies should also be considered for infants of vaccinated mothers if the infants are born to mothers who may not mount an adequate immune response, be immunocompromised. If the mothers are born to mothers who have decreased placental antibody transfer, such as occurs with HIV and malaria. Infants who have procedures that would lead to loss of maternal antibodies, such as ECMO or exchange transfusions, or infants with a substantially increased risk for severe RSV disease. Like as I showed earlier, the administration of the maternal vaccine would be between September and January. The infant RSV immunization for the monoclonal antibody between October and March. And the timing, indeed, for in Guatemala would depend upon the onset of the RSV season. If the RSV season were going to begin in August, then the maternal vaccination would timeline here would be moved back 2 months. If it were going to the RSV monoclonal antibody administration, then would also be moved back 2 months. So your public health authorities would be able to help you in terms of the administration of these products. As I had said before, the indications for the monoclonal antibody clesrovimab and Nirsevimab are exactly the same for infants less than 8 months of age to be administered in the U.S. between October and March. But the dosing recommendations are different. The clesrovimab needs just 1.7 milliliter dose. For the Nirsevimab for infants weighing less than 5 kilos, it's 0.5 milliliters. For infants weighing greater than 5 kilos, it's 1 milliliter. And the maternal vaccine is to be given for pregnant women between 32 and 36 weeks gestation between September and January. As you know, the seasonality differs by climate. In Alaska, the season begins earlier. In climates in southern Florida, it lasts a little longer. And your actual data for RSV surveillance will need to be taken into account with your guidelines. And I'm really sorry I didn't get that data so that I could project for you when you might need to give these products. So just to remind you that infants and young children only get the RSV antibody. They do not get the vaccine. During pregnancy, you only give the Abrismo or the Pfizer vaccine. That's the only one that's been recommended. You don't give an antibody or you don't give the GSK vaccine. And in older people in the United States, there are 3 RSV vaccines that can be administered, but they should not give the antibody. And I think some time to understand this is really important because when we rolled this out last year, there were a lot of mistakes that were made. The advantages of the RSV vaccine were recently summarized in an MMWR that just came out. The advantages of maternal vaccination are that it provides protection immediately after birth. And it also, because it's given in a maternal antibody, and there are many clones of antibody that the mother makes, it will likely be more resistant to mutations of the RSV, which could evolve to a monoclonal. Its disadvantages are that it's reduced if fewer antibodies are transmitted, and it will also need to be seen whether there is a risk for hypertensive disorders of pregnancy. However, that risk is exceedingly small. The advantages of the monoclonal antibody that its protection may last slightly longer. It ensures that the infants get the antibodies, and because the pregnancy is over, there is no risk for adverse pregnancy outcomes. But it does require an infant injection. The product may not be available, which may be the case this next RSV season in your country. And I think that it's fair to say that likely the cost will be greater for it than for the RSV vaccine given to mothers. So what's known to prevent RSV since 2023 in the United States, we have a maternal vaccination. We had Nirsevimab. Now we've added clesrovimab, and that all infants should be protected against RSV either through maternal vaccination or monoclonal antibody. Parents do not appear to have a clear preference. There are around half in the United States in this survey, around half said they had no preference. Around 7% said the mother's maternal vaccination they preferred the shot as opposed to giving it to to their infant. But again, I think that no clear preference has been shown. So thank you very much, and I would be delighted to take any questions that you have.
Comprehensive conference. I think we have echo. Honestly, but I do have a couple of questions. All right. So, Catherine, I have a question. I cannot listen to her.
Yeah, what I'm going to do, I will mute myself when you ask the question so that we don't hear the ringing back. So I'll mute, but I can hear you.
Okay, wonderful. Do you what do you think about co-administering other vaccines to the pregnant women with the RSV vaccine? So,
great question. The co-administration. Okay, the co-administration question is a great one. At this time, there are some data which suggests that there could be some interference with the with RSV vaccine administered to pregnant women and the pertussis vaccine administered at the same time. So there has been one study that shows that there is some inhibition. So I think that we need further studies to look at that. I would probably suggest that giving the pertussis vaccine to the mother and the the RSV vaccine to the mother should not be given exactly at the same time. So I would probably separate them from by a couple of weeks. The rest of the vaccines, the influenza vaccine, I think you could give with the RSV vaccine as well. And so I think that would be the only restriction would be between the RSV vaccine and the pertussis vaccine. And it may just be that we don't have enough studies yet to see how extensive that, but the one study that we have suggests that there may be some interference.
because we do have the vaccine. Just came in to Guatemala as of 2 weeks ago, and it's starting to be, on sale, but unfortunately it's going to be available just for private practice for now. We are going to follow the U.S. recommendation, the ACIP recommendation of 32 to 36 weeks of gestational age. But what do you do with pregnant women that go a little bit over the 36 weeks of gestational age? I mean, is it possible to give it? Is it still beneficial, or especially if the patient wants to get it?
Great question. Great question. Why was the 32, 36 week gestation recommended? And the reason was that there was a GSK maternal vaccination study that was also conducted at the same time as the Pfizer study. In the GSK study, there was a statistically significantly higher rate of preterm birth in the vaccinated group as opposed to the placebo group. All of that happened in low income countries, and a lot of those cases were in South Africa. But because there were some deaths associated with the prematurity, so the GSK study stopped, and they are not pursuing a maternal vaccination. In the Pfizer study, there were not significant differences in preterm births in the very early young infants. There were not statistical differences, but there were larger numbers in the premature cases in vaccine recipients than in placebo recipients. So for that reason, the FDA said, we are going to put some benchmarks on this, and we are not going to let administration of the vaccine occur as soon as 24 weeks. So what we're going to do is we're going to put a benchmark at 32 weeks, just to make sure that this premature issue is really addressed. The 36 weeks is not a bumper because of safety. It's a bumper just because we want people to be vaccinated before they deliver, so that we know from studies of other vaccines that if you give a maternal vaccine less than 10 days before the baby's delivered, that the antibody generation and transfer to the baby is inadequate. So we want to make sure that the mothers are vaccinated long enough that they can make the antibody and that they can transfer it. But let's say a mother came in at 38 weeks and had not been vaccinated, I would vaccinate the mother, particularly in your country, because I don't think you yet have the, and please correct me if I'm wrong, but I don't know that you have Nirsevimab yet. I think if you had Nirsevimab, you might say, well, we'll give the baby the monoclonal because it's not between 32 and 36. But there's no safety concern about giving it afterward. But again, I think that the concern would be whether antibody is going to be made before the mother delivers. Other questions?
We don't have the news. But what about antibody transference through breastfeeding? I mean, because you can still, give a maternal immunization and see if that can, the mother can transfer some antibodies through the breast milk. And I know it's not meant to be that way, but if you don't have any other way, it may, the question may rise.
The role of breast milk antibody in protection hasn't really been characterized very much. And I think that I think there's likely some protection that is afforded, but I don't think that I don't think it would be probably as great as the antibody per se. But I don't think we know for sure the impact of that. So I think that if it was in the United States and a mother came in at 38 weeks, I probably would say, well, let's give the baby Nirsevimab, because we don't know whether you're going to have enough antibody, and so that's what I would do there. If you do not have that product, then I would go ahead and vaccinate the mother, and hope that you have enough time for the mother to make antibody and transfer it. But I think that I don't think we know yet the actual impact of the antibody, the breast milk antibody. That just has not been studied well. I'm not sure whether Pfizer has some of those studies. I can easily ask them whether they have data about that, and then I could send it back to you and give you information, but that has not been published at this time.
Are there any other questions from the audience?
Okay, let me just double check on the YouTube. Make sure we're okay. Right. Well, thank you, Catherine. You've been very, very generous to us. Thank you for your time and your expertise.
Thank you. Let me say
This
one other thing. Let me
conference,
say one other
it's going to
thing.
be also available online for doctors here in Guatemala to consult. And so thank you for your generosity, and I hope we can see you back soon.
Please ask me back. Thank you. Bye now. Bye.